Good afternoon. Thank you to the organizers for inviting me to be part of this panel, and of course to Dr. Balani, who reached out to me to talk about cardiothoracic procedures and how they are practiced in the US with respect to not just truly ambulatory procedures, but shortened length of stay. I'm just going to move this mic a bit. And thank you to all of you for attending. I know it's running late and everyone wants to get going with their lives. So to talk about what are the procedures that are amenable to ambulatory or short stay, patient selection and its role in ambulatory surgeries, and then I'm going to talk about some of the factors that preclude discharge in a timely manner. These are the procedures that are amenable to ambulatory surgery. Some of these are not truly ambulatory in the sense that they don't go home immediately after spending an hour in PACU. These are people that might be admitted for 23 to 24 hours after the operation, just to make sure that there are no delayed complications that have occurred. And this is what the list looks like. It's both diagnostic as well as therapeutic procedures. A brief mention about a couple of surgical techniques which have resulted in decreased length of stay compared with conventional procedures. These are minimally invasive valve procedures or surgeries, and also myocardial bridges. I haven't included off-pump cabbages. It seems that even though they mean well, most of them tend to stay for 2 or 3 days because they have either bleeding issues or pain issues. So I didn't think that it was important to sort of include it in this particular panel. So patient selection is by far the most important factor when you're trying to make cardiothoracic procedures in a truly ambulatory or decreased length of stay. They have to be optimized. If a patient comes to you in florid heart failure, doing anything minimally invasive in the OR is not going to change the fact that he's going to still be in heart failure, and you're not going to be comfortable sending him home. Deciding that the anatomy is suitable for the percutaneous or minimally invasive procedure is also a pretty big deal. And we'll talk about that in a minute. And of course, there should be no surgical or anesthesia surprises when you're doing these procedures. The last factor that I wanted to mention is that it's very important to communicate with the patient about what to look for and when he should come back, because that is important. Because if they don't realize that they're going to go home and they're going to have some degree of pain, the chances are that you will not be able to convince them to have an ambulatory procedure down the road. Looking at some lung brace procedures, these are mostly bronchoscopic or endobronchial ultrasound related procedures, bronchoscopies and BALs that we do with general anesthesia, usually a TIVA approach, or a CT guided lung biopsy, which has a 10% incidence of a pneumothorax post-op. And then the VATS biopsies are also amenable to ambulatory surgery so long as they have no exacerbation of the underlying disease, they don't have complications of the procedure, and they have adequate pain control. Very important when you're practicing ambulatory cardiothoracic procedures is that these patients are sick, whether it's HFrEF or HFpEF. You'll see that they're amenable to volume overload very easily. So volume management is key when deciding to manage them in this manner. A quick word about percutaneous valves. These are patients that can only be enrolled after careful both site selection as well as patient selection. I won't dwell on this for too much. Essentially, you'll find this in the literature. It's the CMS guidelines. But we do them with general anesthesia and TE. I know Dr. Ender and Dr. Mukherjee are sitting in the background laughing at us for still doing them this way, but that's what our surgeons prefer. And they argue with us incessantly that they have the same length of stay. They don't stay longer than 2 days. So, what am I going to say to them? Our monitoring is pretty standard. We do A-lines and big peripheral IVs. We don't do central lines anymore. We don't do percutaneous pacing wires routinely unless we're using expandable valves, or the patient doesn't have a pre-existing pacemaker, and they usually go to the floor. But for this to happen, they have to have none of these complications, which is heart block, no strokes, no pericardial effusions, no dissections, and no vascular complications, which still occur sometimes as these patients are super sick to begin with. The only way these procedures can truly be done is if these patients are candidates for transfemoral. We do occasionally do them as transapical or transaortic, and those patients are not considered ambulatory at all. And they go to the ICU, and they have pretty much like a 2 or 3 day stay in the hospital. The other caveat to this is they should have percutaneous femoral cannulation, so there should be minimal calcification in the vessels, along with reasonable anatomy to fit the sheets for deployment of these valves. Avoidance of pacemaker, we talked about that. And of course, if they crashed on bypass, then all bets are off. I'm going to talk faster. This is a standard form that we create for our TAVRs and our TMVRs. These are a multidisciplinary approach, which gives you all this particular information, as well as size of vessels and the suggested vascular access. And that helps us identify what's going on with these patients. Melody valves, we do them as under MAC mostly. These are percutaneous pulmonic valves with patients who have valvular pulmonary hypertension. The patient sort of loses consciousness when you deploy or do the balloon valvuloplasty, and they're like, oh, what happened? And then, they're fine and they go home. It's kind of an interesting thing. I'm going to skip by this video. Some of the lead extractions and the EP procedures that can be done are also amenable to it, so long as they don't have complications. It's important to make sure that we minimize fluids with these, because especially in the arrhythmia surgery, you'll find that this particular saline to irrigate, and that basically ends up going into the vascular space. These people need to be aggressively diuresed. And of course, this is just a video showing you that this is big pericardial effusion, can't go home. So to conclude, you can do cardiovascular thoracic procedures for a short stay or ambulatory procedures. They basically require multidisciplinary discussions and also patient involvement. And we as anesthesiologists need to have a clear understanding of what the procedure involves. And these patients need to be optimized, and they need to understand their role to make this procedure a success. Thank you for your attention.